On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
Welcome to day 2 of ACC.13. We're here in San Francisco, and this is actually called On the Scene. And I'm thrilled to be joined by a stellar panel. Can you be stellar today?
Absolutely.
You're always stellar. Dr. Peter Block to my immediate left. Peter is a professor of medicine and the director of the structural heart disease program at Emory University Hospital. Good to see you, Peter.
Nice.
Athena Pappas, Athena is associate professor at Brown University and the director of the echocardiographic laboratory at Rhode Island Hospital. Good to see you again.
You too.
You add tremendous charm and wisdom to this panel, Athena. And Dr. Tony DeMaria. Tony is a professor of medicine at UC San Diego and editor-in-chief of Jack, and is the only person on the panel wearing Jack cufflinks, which are spectacular.
Well, it's nice of you to notice.
Thank you. Okay, so we've got some great late-breaking clinical trials. Peter, let me ask you a little bit about Partner 2. Tell us a little bit about that.
Well, Partner 2 was a test of a new technology more than anything else. Randy, Partner 2 was Edwards' attempt to get into the 18 French business, which they needed to do. The XT valve is a smaller valve, slicker, more user-friendly. It is much easier to deal with, goes around the corner and the arch more easily. Technically just a nicer valve than the old Sapien valve and smaller. Sapien valve is big and clumsy, right, but nevertheless still a very good valve. Bottom line of this trial is that because it was a non-inferiority trial, it ended up being, as you might expect, non-inferior. But the good news is, again as you'd expect, that there was a little bit less vascular issues going on because it's a smaller, slicker device, but the outcomes otherwise were pretty much the same. The valve itself is slightly different, a little less cobalt chromium in it, a little lighter, but the structural force against the aortic annulus is about the same, and it seems to function well, no more paravalvular leaks and so forth than the other valve. So on balance, non-inferior, better product. The hope is the FDA will now approve it so that it can be commercially used.
Peter, Tony or Athena, what's your take on that?
Well, one of the things with a smaller size sheath is hopefully we can use it and more patients will have this available to them and not have to go with transapical, which is a more invasive procedure. So that seemed like one of the big benefits as well. And my understanding is you can use a big valve in this 18 French as well, correct?
Yes.
Great.
Tony. Yeah, so I think it's a definite advance, particularly in the patients who are inoperable. The average age was 84, 85, and so in those patients there is a lot of vascular disease, so it really is an advance there. But I was a bit disappointed. Somehow I hoped it would reduce aortic regurgitation, that it would result in a lesser mortality. Still remains over a third, about a third at a year, which is very, very high. So that a definite advance, no question about it, but I think still yet to come is a valve that addresses some of the more pressing issues like aortic regurg.
Right. Yeah, Peter, any comments?
Well, the mortality business, I think, is the comorbidities, Tony. You know that. And it has nothing to do with the valve itself. But the paravalvular leak issue, I think, is an important one. The second generation valves that are coming will probably have to address that issue. That's the major thing that's out there that we have to worry about.
Absolutely. Okay, let's go to another one. Athena, what about PRATO-ACS? What is that?
PRATO was a study looking at rosuvastatin to try to reduce contrast nephropathy, which is a big issue. And they took ACS patients who were statin naive, gave them 40 milligrams of rosuvastatin. They also got hydration and N-acetylcysteine, which is another issue, you might argue. And interestingly, they substantially reduced outcomes, which was increase in creatinine by 0.5 or 25% increase in clearance within the first 72 hours. So it was a pretty promising trial, small number of patients, but seems like an easy thing to do.
Tony, what are your thoughts?
Well, it's a simple thing to do to load somebody with rosuvastatin, and contrast-induced nephropathy is one of those things that just never goes away. You know, as long as we use contrast agents, it's going to be an issue, and this is sure a lot easier than some of the things we've discussed here, like putting catheters in the coronary sinus and draining the coronary sinus blood.
Peter, what do you know as an interventional cardiologist? What do you think?
Well, you know, Tony's right. It has a life of its own. You can't get rid of CIN, right? The problem is that I think in this trial, there are a lot of things going on at the same time in the patients. They were given acetylcysteine, they were given volume, and then they were given rosuvastatin. To tease all that out is a little bit tricky to do, and I'm not sure what the mechanism is thought to be. Do they have any idea of what's going on?
I do not have an idea.
It is water soluble, and so there's some question if that's a benefit. But you know, the reload trial has shown that even reloading patients with statins who are already taking the drug before PCI lowers some of the complications. So maybe this is another reason to go ahead and do that.
Some kind of acute effect.
Could be.
Yeah.
It was a small number. It was, you know, about 500 patients, but there was no difference with the diabetics, which is a little surprising, I think.
Yeah. So Tony, what's Champion Phoenix? Tell us a little bit about that.
Champion Cangrelor, and Cangrelor is one of the antiplatelet agents that's been around that hasn't done very well, frankly, in the first 2 trials. And so this is a trial, I think, that exploited its biologic benefits, more rapid action, more rapid reversibility, so that in the setting of ACS, these are very desirable characteristics in patients who may ultimately need to go to surgery. And so it was a head-up comparison of Cangrelor versus clopidogrel. And the primary endpoint was one of the composites, MI, death, a need for ischemia-driven revascularization, et cetera. And in fact, Cangrelor turned out to be statistically significantly superior, about 1.5% absolute and a 4 or 5% incidence. So I think exploiting the very favorable biologic characteristics of the drug, this study showed that in this setting for ACS patients undergoing PCI, that Cangrelor probably is a good drug. No extra bleeding of a severe nature.
Okay, Peter?
Well, you know, I agree with you. Everything you said is correct. I'm a little worried about what the strategy should be going forward, because these were patients that had both stable angina, unstable angina, ACS, and STEMIs. So if you have a patient that's stable and know probably that it's going to be okay and probably not going to need surgery, I'm not sure I'd use Cangrelor out front. With a STEMI patient where you don't know what's going on, the worst thing that can happen after you front load with Plavix is you take them to the lab, find out they have a left main and terrible coronary disease and need an operation, and you're stuck with the Plavix. So the Cangrelor might be a better strategy for the sicker patients. But where you start and stop those patients and say, okay, these can have a lower cost drug, I'm not quite sure yet. It'll be interesting to see how this goes forward.
They didn't look at that specifically, so I don't know that we could sort of, I agree that conceptually you might want to use it in that group, but it was superior to clopidogrel in all comers. Yep. So the argument might be that we should start using it tomorrow.
Well, but it's going to cost more, right? And the differences are not that terrific.
You know, I think it depends on the strategy, whether you preload clopidogrel prior to the angio or after, and people differ on this a little bit, but certainly for people who preload before, there's an attraction there, since you don't know whether it's going to be the left main multivessel disease.
All right, well that's, since it's a shy panel with no opinions, we are going to take a break, and we want you to join us. We'll be right back.